Assalamu alaikum and good afternoon to all. To err is human, but all of us are striving to build a safer health system. We are gathered here virtually to discuss how we can nurture a culture of patient safety in emergency medicine through leadership, innovation, and simulation. Strengthening leadership serves as a catalyst for enhanced patient safety culture. A question that frequently pops in our minds: how will I know when my hospital is safe? To that question, many of us would likely answer: when I no longer have to call ahead to let the staff know a family member is being admitted. Inevitably, human error will occur in healthcare, and this reality must be factored into safety initiatives. Although improvement programs can help reduce the occurrence of human error, the most effective strategy is to build systems to protect the patient that acknowledges both near misses and actual adverse events due to error. To start the proceedings, we will have a recitation from the Holy Quran.
بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.
We are honored that we have five distinguished guest speakers with us today and will be starting off with their presentations. Kindly type in your questions in the Q&A sessions at the right corner of your screen, and general comments are welcome in the chat box. Our first speaker
Bismillahirrahmanirrahim.
for the day is the lady who guides all of us to ensure patient safety. Dr. Lubna Mushtaque is the head of quality and monitoring directorate at Indus Hospital and Health Network. Dr. Lubna has a healthcare management fellowship focused on quality and patient safety from the International Society for Quality in Healthcare, Dublin. She is an experienced healthcare and quality expert with well blended experience of training, clinical operation, and implementation of strategic goals since 2015. She will be giving us a talk on promoting a culture of accountability in hospitals. Welcome, Dr. Lubna.
I'm going to talk about a culture of accountability in hospitals, which is a just culture. So the just culture, it is a tool used to build a safe culture in an organizations. So the single greatest impediment to error prevention in the medical industry is that we punish people who are making the mistakes. So the people makes mistakes as the earth is human and which lead to the accidents and accident lead to the deaths. The standard solution is to blame the people involved. If we find out who made the error or who made the mistake, we punish them, we solve the problem. Is it right or is it wrong? It's wrong. The common sign of a blame culture is a frequent argument about responsibilities. Which responsibilities we are arguing among ourselves? His responsibility, her responsibility, your responsibility, my responsibility. Furthermore, we are sending emails to the manager criticizing co-workers. Not only this, mistakes are blamed on a specific person's scapegoat. So one of the quality crew, the Edward Deming, he says that the problem is seldom the fault of an individual. It is the fault of the system. Change the people without changing the system, and the problem will continue. Edward Deming further says that 85% of the reasons of failures are deficiencies in the system and the processes rather than the employee. So the patient safety culture, it built on the beliefs, the values, the norms, which are shared by the healthcare staff. So the patient safety culture is what is rewarded, what is supported, what is expected, and what is accepted and what is expected. So it exists at multiple levels. It exists at the unit level, and multiple units combine to develop a departments develop a hospital, and then the system. So in other way around, we can say that the patient safety culture, it exists in each and every unit of the organization. It exists in each and every processes in the organization. So the core beliefs of the safety culture or the just culture is to err is human. We all are human beings and we all are making mistakes. To drift is human. We tend to drift from what we are taught. Risk is everywhere. So our sense of risk diminishes over time. When no adverse event occurs and we are thinking if not occur, it will never be occurring. So, support of our values, we are accountable of the actions regardless of the outcome. We are all accountable. So, we must use our values to evaluate behaviors and the systems. So, what do you mean by just culture? See, in this picture, you can see an iceberg. A small piece is on the surface, and a huge or bigger iceberg is under the water. So, convert this picture into your organization. The visible part, which is above the water, is the behavior of the organization, behavior of the staff. And the part under the water, which is below the water, which is not visible, is the perception, the attitude, the value, the beliefs. So the information of the iceberg, if you translate this information into the healthcare industry, the 4% of the problem, which is above the water, is known to the top management. So the 9% of the problem known to the middle management. However, the 74% problem known to the supervisor and 100% problem known to the worker, which means that the organization culture built on the belief, the norm, it is always embedded from the lower portion and it's trickle up to the upper portion. So if we can convert these iceberg into a triangle of incidents and into a triangle of the harm reporting, the topmost is the fatality and then the serious injury and the minor injury, the near misses, at risk behavior, or you can say the reckless behavior is under the sea. So what do you mean by the just culture? Traditionally, healthcare culture has held individual accountable for all the errors or mishaps that befall under patient their care. A just culture recognizes that individual practitioners should not be held accountable for the system. So the just culture also recognizes that many errors represent predictable interaction between human operators and the system in which they work, recognizes that competent professionals make mistakes, acknowledges that even competent professionals will develop unhealthy norms, shortcuts, routine rule violations. So this is what we call to err as human. So the just culture has zero tolerance for the reckless behavior. So what we need a balanced accountability. So the framework of a just culture ensures balanced accountability for both individuals and the organization responsible for designing and redesigning and improving the system in the workplace. So if we can talk about the just culture, a fair and why it is important to have a just culture in an organization. Safety culture participates in safety activities, in the ongoing activities in the work environment. Improving patient safety reduces risk by focus on managing human behavior and designing and redesigning of the system based on the learning from the occurring of incidences. So if you can translate again this triangle into the right-hand side triangle, which means that one fatality is seen over the surface of the water. Everybody says that there is a mortality, there is an increased mortality rate. But behind the increased mortality rate, what are the serious injuries? What are the near misses? What are the reckless behavior lying under the water, under the organization, which is hidden? So one fatality, roughly it means that 30 minor incidences. You can say that 300 near misses incidences and more than 300,000 unsafe eggs. So what to do? This is, and always in the organization, we are working reactively. We are not working proactively. If we can work proactively, what will happen? If we will work proactively, the major incidents will go down, the loss of the time go down, the medical incidences, the operational incidences The near misses and the reckless behavior will improve if from everyone in the organization is behaving in a proactive manner. So the medical error has always been with us. We cannot exclude ourselves from the medical error. So if you can have just a look on this picture, do you think is there any possibility for error? What is the difference between the dopamine and dopamine? So consider the following situation. For example, two nurses select the same wrong vial of the intravenous medication from the dispensing system. So one nurse administered the drug, causing cardiac arrest. The other nurse realizes the switch when drawing the solution from the vial into the syringe at the bedside. How do we approach the nurses and investigate the solution, investigate the situation if somebody will not report? Another example. The attending physician tells the resident, this is everyday example from our own situation. The attending physician tells the resident that physician to obtain a specific blood test. The resident forget. Fearing the wrath of the supervising physician, the resident reports that the result is normal. So how do we deal with this breach? So the surgical timeout. A surgical team does not perform timeout. A surgical team timeout on the ground that never occurs. So in only one of these scenario does an adverse event occur, yet a just culture. With its insistence on a value-based culture and a shared accountability demands that all of these situations be addressed. However, individual practitioners should not be held accountable for mistakes made in a system on which they have no control. So in the first example, if we can say in the first example, further investigation, the example of the wrong vials, if you can go back in this example, in the first example, further investigation shows that two vials of entirely different medications look alike in a shape, size, color, and a print. This incident waiting to happen did happen to the first nurse and her patient. Human error was involved, but this nurse should be consoled and supported rather than be punished. In this example, the resident physician falsified patient data, which cannot be condoned and must be addressed. Honest disclosure without fear of retribution is an important characteristic of a just culture. The surgical team cannot function outside of the value-based principle designed by the organization, although this surgical team has never been involved in an adverse event, one may occur in the future. As for the respiratory therapist, for example, in just culture, we are concerned for the safety of our patient and we are concerned for the care for each other. No punitive investigation is necessary. So in the past, the culture of healthcare focuses on placing blame on the healthcare providers whenever there was an error or bad outcome occur. And still, it's ongoing. With this kind of the culture, healthcare providers were hesitant to report any error due to the fear of punishment. As a result, such occurrence were never reported. In the presence of the just culture, to improve reporting of the errors, organizations moved to blameless culture. However, this type of culture did not succeed due to the lack of accountability, and the practices did not promote a learning environment that promoted patient safety. Today, the focus of the healthcare is patient safety, and just culture balances the assessment of systems, processes, and the human behavior when an error or event is reported. So the goal of just culture, what is the goal? The goal of just culture environment is to design safe system that will reduces the opportunity for human error and capture error before they reach to the patient. So the duties of the organization and employees in the development of the just culture, the duties to avoid causing unjustifiable risk to the risk or harm, the duty to produce an outcome, the duty to follow a procedural rule. Number one, the duty to avoid causing unjustifiable risk or harm includes do the right thing from the patient, for the patient, do the right thing for the co-workers, do the right thing for the family and the visitors, do the right thing for the organization, and how to produce an outcome, error-free outcome, or to improve the patient experience of care. How it will happen, we will go after a few slides. We will discuss this as well. Duty to follow a procedural rule is how to do this one, to identify the patient correctly, do the correct patient identifier, hand hygiene, proper hand hygiene, dietary protocols to be followed. Patient need to be restrained who is in need of the medication, proper medication administration with the help of the rights of the medication administration or dispensing or the storage, control substance discrepancies. So the just culture model based on the mission and values, the duties, the breaches, and the consequences. Where we are at with accountability. An experienced surgeon, if, for example, an experienced surgeon see a new piece of equipment at a conference, back at the hospital, a sales representative persuade him to use the equipment for a procedure. He has never used the equipment before and accidentally punctured the patient's bowel. The surgeon repairs the bowel and the patient recovers fully. The OR has a policy that says new equipment will be officially approved and training will be conducted prior to its use. So here there was a breach of the policy. These example addresses an aspect of just culture that goes beyond ensuring that employees. Just culture is a culture in which everybody in the organization feels free to raise the safety concern without fear of retaliation. So what you have to exercise, look at your processes and consider how you will include human factor in your design. Think about how you will observe your processes through fresh out. Continuous process redesigning and redevelopment will ultimately lead towards the safe patient care and the just culture. So what we need now, this is the time to move. This is the time to move from where to where. So this is the time to move from his fault, her fault, my fault, your fault, their fault, not me. It's the time to move towards just culture in which everybody has the right, everybody needs to report without fear of retaliation in order to develop a safe patient care organization. So what are the steps towards just culture? Communicate. We all know that the communicate, trainings, development, these are the basic steps of development of the safe culture. Led by example. How to lead by example? Safety is more than talking the talk, it's walking the walk. So the important thing is to develop and implement a positive reporting processes. Reward employees who report safety hazards or concerns. A positive safety culture will be much easier to build and maintain when employees feel comfortable reporting concerns and believes that the reporting process is positive. Involve your workers. Building and maintaining safety culture starts from the ground up. Another way to build strong employees buy-in is to involve them in the process of development, in the process of redesigning and restructuring. So this is the time to build a positive safety culture because safety is everyone's responsibility. With this slide, I'm going to conclude my presentation. Thank you very much.
Thank you, Dr. Lubna. So, a dear colleague and a well-wisher of Indus Hospital, Dr. Megan is one of the driving forces behind our certification program in emergency medicine at the Indus Hospital and Health Network since 2018. She is a
Assalamu
global
alaikum, everyone.
She is a Global Emergency Medicine Fellowship Director and an Assistant Professor of Clinical Emergency Medicine at Perelman School of Medicine at the University of Pennsylvania. She has a special interest in emergency medicine education and training programs, development, as well as emergency care system improvement, and together we are striving to bridge the gap in emergency medicine in Pakistan. Dr. Megan will discuss innovation in education in emergency medicine. Welcome, Dr. Megan.
Everyone, my name is Dr. Megan Rybarczyk, and I am currently the academic lead of the CPEM program. I am the Penn Global Emergency Medicine Fellowship Director, and I'm Assistant Professor of Clinical Emergency Medicine at the Perelman School of Medicine at the University of Pennsylvania in the United States. I thank you for the honor of allowing me to participate in this session and in this fantastic conference, ICON 2022, Beyond the Call of Duty. I have no disclosures regarding this talk. I will be mentioning several online resources and tools, but I have no conflicting relationships with any of the companies or institutions. Additionally, you may see some photos throughout this talk with individuals without masks, and these are of prior cohorts of the CPEM program and were taken before the pandemic. So let's go ahead and get started. Patient safety is of the utmost importance at all levels of the healthcare system. This is particularly true in the emergency department, given the often overcrowded, busy, and unpredictable nature of this environment. As a result, a focus on this important aspect of providing patient care is an essential part of any EM training program. Unfortunately, traditionally, this has often not been the primary focus of education. Patient care or treatment has been, and patient safety, like other somewhat abstract topics like ethics and professionalism, has been in the periphery or in the hidden curriculum. Therefore, it is only by intentionally incorporating educational initiatives centered on patient safety throughout all levels of training that we can work to more explicitly address this topic and to provide improved patient care. So the objectives of my talk today are to review educational methods and core topics in patient safety, to highlight 3 methods of innovative instructional implementation, and to more broadly discuss additional strategies, innovations, and advancements in patient safety. In many educational systems over the last couple of decades, there has been a paradigm shift to a more learner-centered model. Curricula are now more competency-based with formative rather than just summative assessments. With this approach, trainees are able to be more active agents in their learning and in tracking their progression through core milestones, such as medical knowledge, patient care, and professionalism. This paradigm shift should be applied to patient safety curricula as well, and healthcare organizations should strive to have both institution-wide as well as specialty-specific curricula. No matter what the level of the curriculum, however, institution-wide or specialty-specific, it must incorporate or include event reporting mechanisms, as well as longitudinal and interdisciplinary activities that are implemented through multimodal learning. These are key components of any patient safety curriculum. Furthermore, the following are core topics that should be considered in any patient safety curricula. These should be tailored to the type of curriculum, and they can be both explicitly taught, as many of them are in, for example, the Healthcare and Leadership Quality track at my home institution, UPenn, or they can be more implicitly woven through a curriculum such as they are in the CPEM program. First, in the UPenn program, which is open to all residents, these topics are covered throughout the core curriculum over 2 years. Residents who choose this track also dedicate their elective time for this work, as well as for participation in unit-based clinical leadership teams, in longitudinal mentorship, and on a QI capstone project. The other example I mentioned was the CPEM program. For those who do not know, CPEM, or the Certification Program in EM, is a 1-year training program in EM designed to bridge the gap in training as the specialty further develops. In this curriculum, patient safety is an underlying implicit theme that can be recognized in many sessions, such as those listed here. By including everything from how to manage difficult conversations to formally learning to examine the literature in order to apply evidence-based practices, trainees learn core concepts to address patient safety. So now that I have introduced you to some of the key principles and core topics of patient safety curricula, how can we practically implement these? Now, before I go into more specific examples, whatever is implemented should focus not only on what trainees learn, but how they learn. As we know from Kolb's experiential learning cycle, trainees need repetition with progression, from observation to feeling. And it is only through repetition using multimodal learning that trainees really advance from being novices to experts. Furthermore, we know not everyone learns the same way. A curriculum that includes multiple learning modalities is imperative to ensure progression from knowledge acquisition to application. And so here I will focus on 3 more advanced learning modalities: simulation, small groups, and asynchronous learning. And I will discuss some innovations in each, many that we have used in the CPEM program, in order to show how to practically implement a patient safety curriculum. First, simulation, which can include both low fidelity and high fidelity models. Additionally, incorporation of things like live models, moulage, real equipment, separate procedural models, images and videos, vital sign simulators, all of these can enhance the simulation experience for trainees, as well as help guide formal debriefing sessions after each scenario to focus on patient safety issues. Also, multiple patient scenarios that help trainees develop skills in triage and time management can also be used to demonstrate how these factors can affect patient safety. Additionally, tabletop exercise can help teamwork and communication skills, which are necessary to ensure patient safety. These, like simulation, are also well suited for multidisciplinary teams and can provide environments that help empower all levels of the patient care team to be able to recognize and to address patient safety concerns. Another novel approach, especially in the area of millennial med ed and the increased use of gamification, is the use of escape rooms. These popularized activities have been shown in the literature to also build teamwork and to improve communication. Finally, throughout the COVID-19 pandemic, we have seen a shift in remote or distance learning. While this creates a challenge for hands-on activities such as traditional simulation, it has resulted in the expanded use of existing software such as things like PowerPoint, Google Slides, and video conferencing, as well as innovations in medical simulation apps that have resulted in e-simulation. The next modality to cover is small groups. Now, the ideal group is about 4 to 5 trainees per instructor or facilitator, but potentially larger groups depending on the topic. For example, a larger group might be better for a facilitated discussion, such as what usually occurs in root cause analysis. Other types of small groups or collaborative learning modalities include PBL, TBL, and CBL. These are very effective modalities for teaching core concepts and patient safety. As you can imagine, a learner to instructor ratio of 4 to 5 to 1 will require additional faculty. This is a challenge across the board in both low and high resource environments, as faculty often lack formal training in these educational methods as well as in patient safety. 2 innovative methods to address this challenge are the Jigsaw Method, a type of peer-to-peer teaching of a concept after an initial training session by a single faculty member, or at a higher level, a training of trainers where individuals are trained as educators to be able to administer a course on their own. Finally, asynchronous learning. So much of what we do focuses on the formal learning environment, but that we often fail to address everything else that our trainees have access to. Especially in medical education today, trainees have access to an almost unlimited number of resources, everything from books and articles to podcasts, question banks, and online medical simulation apps. This allows for trainees to pick resources most tailored to their learning style and pace. And this is great, but this can also create challenges regarding patient safety. In fact, there has been such an explosion of FOMED, or free and open access medical education, and MOOCs, or massive open online courses over the last few years, that educators must help trainees navigate these, as well as their pitfalls in terms of patient safety. Many of these are not peer reviewed, so trainees must be taught to appropriately triangulate and verify material. All of the ones listed here are some of the most commonly used in EM and pediatric EM, and some of these even have explicit material on patient safety, which is great. But again, these do need to be approached critically, and trainees need assistance in navigating these using a patient safety lens. Additionally, I just want to highlight that particularly with the rise in distance learning due to the pandemic, there are many applications out there to help support portions or whole curricula in general. This is a very short list of the many, many examples that are out there, many of which have been used in the CPEM program. Use of these resources can allow for wider and deeper engagement in remote learning, as well as additional methods for assessment. Now I've talked a lot about education and innovative learning principles and tools that focus on teaching individuals about patient safety. But the only way to really ensure that patient safety is given the utmost priority in a healthcare system is to also teach the institution the importance of it. Too often, academic structures reward grants and publications, and too often, healthcare delivery systems reward executive, administrative, and financial structures. As a result, in many institutions, there needs to be a change in work culture to focus on patient safety. And a couple of ways to do this are to focus on patient care rather than the business of medicine, as well as to promote a culture of mutual respect at all levels. And this can be accomplished through very simple activities such as multidisciplinary and multi-level patient safety meetings, as well as the financial investment in patient safety initiatives proposed by any staff, trainees, or faculty at any level, and even patients and families. Additionally, mutual respect empowers individuals to speak up about patient safety concerns. Now, tangible incentives such as grants for patient safety initiatives are great, but people in healthcare also have intrinsic motivation to do good, and they often harness and innovate on the energy derived from fulfilling a shared purpose to improve patient outcomes and experiences. Healthcare improvement draws on learning and creativity and is inspiring and energy giving. Therefore, focusing on people and setting them up for success right from the start and throughout their careers will automatically result in innovative approaches to address emergency challenges and ultimately, overall, better patient outcomes. This starts with comprehensive and standardized orientation, is carried through investments in wellness and employee-driven initiatives, and in mechanisms for addressing burnout, and is fully manifested in developing career pathways, in quality improvement and patient safety for faculty and staff. This not only ensures sustainable leadership in this field, but ensures that there are additional educators in patient safety, as well as drivers of institutional change and improvement. Additional strategies include some of the following more specific initiatives. First, as I mentioned earlier, as a key component of curricula is reporting mechanisms. All institutions should have these, and they should be easy to use. The process should be both protected and transparent, and reporters should get feedback on their submissions. Second, the inputs to these reporting mechanisms are most often negative events and outcomes. These are often discussed in case conferences, which are sometimes called M&Ms or morbidity, mortality reports at some institutions, or kind of safety one approaches. Studies have shown that these are effective, but as you can imagine, they can have a negative connotation. I would argue, and this has been proposed and used in many places, that these should be balanced with positive reports, or what is called a safety two approach. What we need to do is root cause analyses of complex situations that have great outcomes just as much as we do it for unfortunate outcomes. So M&Ms should be conducted along with S's and S's, or successes and saves, every time. Finally, in order to advocate for any change, evidence is needed. You need not only staff, trainees, and faculty trained in QI and research methods and patient safety, but you need the data for them to analyze. Ensuring that the institution has ways for this to be obtained, not only through the reporting mechanisms, but also through the implementation of electronic health records, or EHRs, is imperative. And these EHRs need to be tailored to patient safety data collection. Furthermore, once data has been obtained and initiatives implemented, EHRs can be great tools for implementing some of those initiatives, such as clinical decision-making tools and even artificial intelligence and screening tools that can be used to help with patient safety. Two of the caveats to any of these initiatives are: first, stakeholders should be included in the implementation of any process change. Too often we see a new tool that is incorporated into an EHR supposedly to enhance patient safety, but no one uses it because they don't know why it's there, or it is too long to use in a fast-paced setting like the emergency department. For example, a long sign-out report versus a tool like iPass that's easy to remember and very quick to do. Second, for whatever reason, Second, for whatever is done, processes should be in place to share the outcomes and initiatives broadly, not only throughout the institution, but potentially across networks and regions. In some areas, whole patient safety networks have been developed to share resources and both effective and ineffective strategies with the goal of providing improved patient experiences and outcomes overall. So, to summarize, patient safety is an educational priority and must be incorporated into curricula both explicitly and implicitly, and both institution-wide and within each specialty. Multimodal and multidisciplinary training is paramount, and learner-centered educational advancements, particularly through the implementation of innovations and technologies, is key, with the caveat that learners must also be guided on how to properly assess and organize the vast amount of resources they are now exposed to. Finally, to ensure patient safety, it not only has to be a focus in academic programming, but also in the institution as a whole through a culture change, the development and support of people, and through the acquisition and use of high-quality data. Stakeholders must be involved in the development of any initiatives or studies, and both positive and negative experiences and outcomes, as well as resources, should be shared for collective education and advancement in the field of patient safety. And with that, I thank you for your time, as well as again for the opportunity to present here today. Thank you also to Dr. Saima Ali for organizing the session and her leadership in CPEM, as well as to my fellow speakers and the chair of this session. Thank you also to Drs. Ghazan Farslim, Adil Khatri, and Sama Mukhtar, and Bilal Hassan for their leadership and coordination of CPEM, as well as the staff and trainees involved with the program. I thank you again, and I welcome any questions during the discussion panel. Thank you so much.
Thank you, Dr. Megan. So I would like to emphasize that kindly put your questions in the Q&A sessions at the right-hand corner of your screen, and general questions and comments are welcome in the chat box. So our next speaker, we welcome Dr. Taj Hassan, an immediate past president of the Royal College of Emergency Medicine, who is currently working as an emergency medicine consultant at the Leeds Teaching Hospital NHS Trust. His major interests include emergency medicine system design, creating workforce resilience, and sustainability through leadership development. Internationally, he has been involved in leadership training programs for the International Federation of Emergency Medicine, IFEM, and linking to help support developing countries in their emergency medicine system development. Dr. Taj will be talking about leadership in emergency medicine. Thank you.
So, Assalamu alaikum. My name is Dr. Taj Hassan. I'm a consultant in emergency medicine here in Leeds in the UK. And I'm also fortunate enough to be the chair of the International Committee of the Pakistan Society of Emergency Medicine. I'm absolutely delighted to be able to contribute to this track. Thank you to the organizers who put on what is an absolutely fantastic program. And I hope that the session will generate lots of discussion, both afterwards as well as in the coming days and weeks. So my next 15 minutes, I've been given the task of talking to you about leadership in emergency medicine, a subject which is very close to my heart. So if you remember the great Martin Luther King Jr., who said, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forwards. And I think for me, and my personal journey in emergency medicine, it's certainly something that was inculcated into me by my parents and my father, that you have to find a continual way forward. And I think emergency medicine, especially the very tough environment that we work in, we are very good at finding solutions. We have to find solutions because often we only hold a few pieces of a very complex jigsaw for a patient, and we work in this ever-changing dynamic environment. I want to talk to you for the next 12 minutes or so about vision, planning, and delivery, both as an individual, you may be a junior trainee in emergency medicine, you may be an experienced consultant running a very busy emergency department. But I think you as an individual, or for people like myself who are fortunate enough to sit in some positions of responsibility, all of us have positions of responsibility where we want to drive change, and we want to drive change that is good for our patients, our staff, and ourselves. So these are the three things I really want to concentrate on. Okay, so who are we? Well, as emergency physicians, actually, we do all of these incredible things because our specialty is the best specialty in the world. We are teachers, we are resuscitationists, we are mentors. At heart, we are emergency physicians. And through our careers, I think we navigate various phases of our lives, and we touch upon these individual roles. So I think be honest with yourself, decide what you do well, what you want to aspire to do well, and how you're going to get there. What is your leadership journey? And that will then allow you to link with your mentors and your supervisors and yourself to set goals both within the short term, medium term, and then the long term. And that will be part of the ultimate ingredients for success. If we look at where Pakistan is in emergency medicine, very much, I think, in the foothills of development, I think is probably a good way to say so. There are less than 100 emergency physicians in the country for a population of 220 million. But that is no different to many other low middle income countries. The WHO in 2019 adopted a resolution on emergency and trauma care. And the Director General said very clearly, no one should die for the lack of access to emergency care, an essential part of universal health coverage. So all people around the world should have access to timely life-saving care that you deserve. We know that unfortunately that does not happen in many countries, and Pakistan faces such challenge. And they broke down the need to divide emergency care frameworks into three parts: what happens at the scene, what happens in transporting patients to hospital facilities, and what happens at the facility. And I'm not going to go through those phases, but what I'm going to go through is your role as an individual or as a leader to be in any of those spheres, because no doubt you'll either work in one or more of those spheres in your careers now or in the future. So vision. Vision is a tough balancing act. You have to be honest with yourself, and you have to take on board the views of friends, colleagues, and of course your supervisors and teachers. I'm going to give you a few top tips because I think that's quite a good way of perhaps focusing down on the time we have available. Tip 1, be energized and be kind to yourself. Emergency medicine is a tough specialty. There is absolutely no doubt about that. But it is so enriching and it is so energizing also for yourself when you do it well. I was lucky enough to chair the Royal College group on creating successful, satisfying, sustainable careers in emergency medicine back in 2011, 10 years ago. We were the first college in the UK to highlight that actually what you need to do in medicine is to care for people themselves, because if we do not care for the carers, then we will not be able to care for our patients. Emergency medicine has one of the highest burnout rates in any specialty. But if you do things well, and these documents are available on the Royal College website, please have a look at them. They give you some top ideas on how to care for yourself, your team, your system, and that allows you to ultimately have successful careers. We know that negative inputs like stress, internal conflict, time, energy demands can lead to burnout. And this model by Dunn et al. Identified that actually if you have good support structures, if you have good social health activities, if you have good mentorship, and you have great intellectual stimulation, that creates an energy bank and a mental bandwidth that will allow you to have greater success and resilience in the future. I'd recommend that mental model to you as something to consider for the future. Tip number 2, what will I learn today? And this is really about the joy of practicing medicine, but the joy of learning every day and having a growth mindset. So we all would aspire to have a growth mindset, but we all know that at times we can be quite fixed in our views. And again, the power of reflection and the ability to say that this is something that I need to review tonight or tomorrow or the day after when something goes wrong, and having a constant growth mindset is really important. What's my focus for today? So coming on shift, you may be lucky enough to work in a department where you have a clinical educator working. That probably isn't the case in Pakistan at present because there aren't enough trained emergency physicians, but you will no doubt have senior role models, and there are a whole range of fantastic people in the various training centers for emergency medicine in Pakistan, and I really encourage you to connect with them and gain the best possible opportunity, because that is what will lead you to, again, connect to that growth mindset. In the UK at Royal College a few years ago, I was lucky enough when I was in my presidential role to be able to put into place a strategy whereby we developed clinical educators in emergency departments in UK departments. And that was a first, and that led to a report in 2019, which has rolled out clinical educator programs so that on the shop floor, there are dedicated clinical educators for trainees, as well as those working clinically. Planning. Let's move on to planning. Planning is all about starting your shift and deciding how that shift is going to be a really successful one. And part of it is about doing great departmental handover. So if you're the team leader, how do you make sure that your handover is pristine, is solid, and connects really well to the oncoming team? If you're a team member, how do you contribute? So leadership is not about just being a great leader, but also being a great follower. And finally, it's about knowing the team that you're going to be working with. What are their skills? What are their attributes? What are the things that they will need support for? And so having that in your planning on a daily basis is really instrumental to running a great shift. building great game plans. So that's much more around an individual basis. One of the things that we know when things go well with a patient, we can talk about it for days when we make a fantastic diagnosis or we deliver on a therapeutic plan and they get better in front of us. But we also know that when things don't go well and we haven't described our management plan really well, patient care can suffer. And that can really get at you on a daily basis and live with you for weeks, if not months, if something bad turns out. So make sure that your management planning, both for your patients and also the other team members, is really pristine, well described and well documented. Managing workload and delegating well. So that's the big deal in emergency departments, because the workload is ever present. It's like a constant tsunami of activity. And you have to work out the ability to prioritize your work, to decide which patients need you and your skills, and which patients can be managed by others. So that's something that, again, you will learn with experience. Go out, read, discuss with colleagues, and really focus down on making sure that what you do is really tight, pristine, and you're able to juggle those 2 or 3 or 4 or 5 balls at any one time if you can. Because otherwise, again, mentally, it becomes quite wearing. Once it becomes quite wearing, your ability to function as an emergency physician becomes compromised. Tip 7, communication. We know that above everything else, if you communicate well with your patients, with your colleagues, with the nursing staff, with your specialty colleagues, if you are clear, positive, polite, that will lead to good care for the patient, will minimize conflict, and it will lead to you having a great day. So look at your communication skills. What happened on the day when you communicated really well, and what happened when actually you were a little bit curt, a little short, a little frustrated, and why on reflection could you have done that better? That's part of leadership and part of delivering that shared vision to your team members. Let's talk about delivery now, the last component of what I really wanted to talk about to you today. Delivering great care, great clinical care is what we're all about, as we know, and that takes leadership. But what does that actually mean? Well, it means, for example, and we could talk about this all day, but I've got about 6 minutes. Let's talk about 3 things. One is being the team leader in the resuscitation room. So that might be for a trauma that's coming, you've had a pre-alert or a medical emergency. And something called the 0-point survey is by Cliff Reed and colleagues, is quite a nice model. You will have your own preparatory model of how you prepare for an incoming patient. If you haven't got a preparatory model, I might suggest that one, or make up your own that is addresses those key components. The second thing I would want to highlight for you is what happens when things go badly wrong. You might get a young death. How do you debrief? How do you debrief with your team? How do you debrief yourself and yourself to make sure that you are okay? And how do you make sure that it's a positive experience for everyone? If you don't have a hot debrief strategy in your department, I'd suggest you might want to look at this one or something similar, because that's actually really, really important. What we do is unique. We manage cases on a daily basis. We deal with people's lives, and sadly, too many occasions, the outcome can be bad, and it's important, therefore, to have strategies like this. The last thing I would say to you is about something I call the 3-minute extra rule, and it's really about when you finish your patient consultation, give them an extra 3 minutes at the end just to explain to them again in their lay language what's happened to them, what's going to happen next, what they should do if things don't work out so well. and you will see the gratitude in their eyes. And that's really energizing for you personally as an emergency physician. So delivering great clinical care, I've just highlighted 3 things there for you, but actually that's part of being a great leader, to role model those sort of activities. And I'd ask you to take that away, and I hope that will resonate for you. Motivating and caring for your team. So this again is a subject in itself, but really look at the tactics that you employ on a daily basis if you're in a leadership role on the shop floor. How do you role model? How do you care for your team? How do you care for yourself? What are you going to do better tomorrow or the next week? It's something I try and challenge myself on regularly, and I have good days and I have bad days, and I think that's part of our life journey. But I think the more you think about it, the better you will be. And lastly, but not least, kindness, humor, and neutralizing conflict. The emergency department is one of the best environments for actually conflict generation, creation, but if you handle it well and are kind, considerate, polite, and with a bit of humor, you will neutralize and minimize conflict, and that will allow your team to function better. As in the words of Maya Angelou, and what she said, it's learning that you may forget what they said. People will forget what you did, but people will never forget how you made them feel. Just a few last points about how we've, some of the leadership journey I've been on with friends and colleagues in Pakistan over the last few years. I think one of the first collaboratives when I started in 2016 as president, and we managed to jointly create a conference in 2017 following the development of the Pakistan Society of Emergency Medicine. You'll see Junaid there, Ayaz Abbasi, Abdul Bari, a whole range of other people who were really instrumental in helping us to develop on that vision. And subsequently, a number of workshops that developed, and in 2019, we developed the leadership summit, at which we were lucky enough to have Professor Nashran Burki attend and support us. And that led to the roadmap for emergency care that we published in September 2019. And what I'm really want to take away from this slide for you is to say, actually, you can bring people together, you can create an approach, and the change may not occur immediately, but bit by bit. And I think that is what is happening due to the talents of all the people in Pakistan who are coming together to really drive the Pakistan Society of Emergency Medicine. So congratulations to them. That has allowed progress to occur, not just with the developments of the Leadership Summit, but also the virtual conference we ran earlier in the year. So, congratulations to all those that have been involved, and please, I encourage you to join the Pakistan Society so that we can continue to work with you all to drive the successful change that Pakistan really requires. I want to finish really at the end with a few things that we've done. We've developed partnerships and networks, both nationally and internationally. We're working with the CPSP on improving training programs and infrastructure support. We continue to work with the PMC, which of course is under new leadership itself. And finally, with the federal and provincial governments, we continue to engage with them so we can integrate the roadmap for emergency care and its activities for future positive change. Barack Obama, in his one of the last years of his presidency, said, "Change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek." And I really encourage you to be involved, be that positive change. And my last slide is emergency medicine is the best specialty. These are words that I ask people to describe emergency medicine when we were celebrating our Royal College 50th anniversary. And you will see there are so many positives in there. Thank you very much. It's been a pleasure talking to you today.
Thank you, Dr. Taj. Our last speaker for today is Dr. Jabeen Fayyaz, the lady who took us on an adventurous simulation ride this year. She is our simulation guru, who is well rooted in Pakistani healthcare and is cognizant of challenges that we face day in and day out. She is a simulation educator, advanced pediatric life support course director, and is currently working as an assistant professor of pediatric emergency medicine at the University of Toronto, directing the Pediatric Emergency Medicine Clinical Fellowship Program. Dr. Jabeen is also a PhD candidate in simulation in MHPE at MGH, which is Mass General Hospital, Harvard Medical School. She is going to be talking about how simulation can promote patient safety and quality improvement in acute care settings. Thank you, Dr. Jabeen. Welcome.
Thank you so much, Urooj, for such a kind introduction. And I would like to congratulate the whole team of Indus Hospital for pulling up such an amazing conference and an amazing program. And I'm so honored and blessed to be part of it. So what I'm going to talk about in the next 15 to 20 minutes, a little bit taking a step back and then talking about some of the strategies that we can utilize, which is obviously my passion is simulation-based education, and how can we utilize it to prevent those harms or errors to reach to the patient. No conflict of interest or disclosure here, and I just want to acknowledge the land on which SickKids operate. My presentation will be based on strategies or some of the experience from the literature and also from my own practice, which I'm going to share with you all, that will be beyond the teaching and learning. That is, how can it be utilized for provider performance improvement and improvement of teamwork, how simulation can help us in system testing, and then patient safety and quality improvement. So I will be going to talk about interprofessional training, latent safety threats, acute event clinical debriefing, community outreach via simulation, how can we support our communities, and then CPR coach roles. Let's talk about interprofessional team training in Situ. So team training in Situs are the simulations that are physically integrated into the clinical environment, because we do have this big sim centers where lots and lots of cool gadgets are there, but are they translating actually when we work in the clinical environment? Not always, because our clinical environment is unique and it is quite different when we run the same resuscitation scenario in actual clinical work environment. So it has been very, very important to have team training in situs, either resuscitation, either trauma, either on the floor, anywhere you can implement that. And if you look into the literature is full of articles that will talk about that how this team training in situ, which is very low cost simulation program, can help in not only improving in the team dynamics, in team performances, but also to make your environment or workplaces safe. At SickKids, we do have implemented this team training in situs, which is interprofessional since 2014. We run 12 scenarios every week between 8 to 10 a.m. and they are unannounced. How do we decide about curriculum? It is based on the common ED presentation, the M&M scenarios, or any safety report that has been filed, any new protocol, any new process that we implement, we incorporate them into our team training in situ. And then I will show you a video of our team training in situ happening, and it is pre-COVID, so you will see a lot of difference and lot of...
Good morning at 9:43 in the morning, and you are in the emergency department, and nurse rolls in a patient for you and tells you that this is a 5-year-old boy brought in at 9:43 a.m. today and was complaining of blurred vision, vomiting, and severe abdominal pain. For any additional history, you may ask me. We do not have a parent in the room right now. They're just going in. If that's your number. What was the age? What was it? Sorry? Age, what was it? He is 5 years old and coming in with blurred vision, vomiting, and severe abdominal pain. All right, so I'll be the TTL or the coaching leader. Can you please get monitors on the patient, go down and do a primary assessment, airway review.
So you can see here, well, that the whole team, which is actually working in the clinical environment, is working here, which comprise of nurses, physicians, learners, respiratory therapists, and then some of the sim educator. And we always incorporate nursing educators in our team training in Situs because they can talk about their perspective, which we might not be aware of. We utilize checklist, which is specific to the scenarios, and then the team performance is assessed on team score, which is a validated score. And just to remind here, the assessment is formative assessment, and the notes which is taken is utilized for the debriefing, and the focus is on the leadership, teamwork, task management rather than individual performance. So I really love the idea Lubna has rolled out as just change. So this is one of the example of just change, that changing your focus from individual performances to the team performances. There's a recent article which is published by my mentor, Jonathan Barry, who talked about the use of statistical process control chart to evaluate the interprofessional sessions. And then it is a well-known process measure in the quality literature. And you can see here that after the implementation of the team training in Situ, there is a change, which is a remarkable change, and then the plateau will happen. So based on this plateau, because usually team training in Situ, we have 30 full-time staff physicians, and then to have each staff physician to go through these team training in Situs, it takes usually 2 years. And if you are lucky, you will get the same case. If you are not lucky, then you all the time you will get the different cases. So how will you ensure the uniformity, or how would you ensure that all the staff physicians or the faculty members are maintaining their skill levels, so that I can be sure that no matter what time of the day, what day of the week, whether Jabeen is working, whether Jonathan is working, or whether Susie is working, my child is getting the same care, which is safe quality care to our patient. So based on that model, we implemented a competency-based medical education for the faculty and fellow, which is one of its own kind in Canada for the faculty member. So basically, the faculty are the participants and the faculty are the facilitators. It usually happens 4 half days in a year, and we divide it into technical as well as resuscitation. And technical is further divided into point of care ultrasound, emergency procedures, and then resuscitations are again IP teams, interprofessional teams, including the nurses and RT working in it. And there are medical cases as well as trauma cases. We have developed the whole PEMSIM website where all these resources are available. And this is one of the example of one of the resuscitation lead, where you have the procedures, you have scenarios, and there are different objectives of each stations. There is pre-reading material available along with the guidelines, pathways, checklist, and then the same checklist that we utilize in Situ team trainings. We use it for the formative assessment and for debriefing points to document. And then the global rating scale of the team performance is also being assessed. Recently, we published this, and then up till now, like this is the first iteration, and second iteration is in process. So 40 physicians and 48 registered nurses attended these courses, and they have evaluated it very high. And then the barrier of implementation were having faculty freed for this much of time, time commitment, clinical schedule, etc., were found to be the barrier. The second thing which I want to talk about is latent safety threats. The latent safety threats are the actual threats which are present in your clinical environment all the time, like a ticking bomb, but it has not reached to the patient. And by doing the simulations, especially the in situ simulation, is a good strategy to identify those latent safety threats. And then if you look into the literature, it has been well defined as a measure of quality improvement and patient safety ensuring. So this is a result of the pilot study that has been done at SickKids during my teaching scholarship program. We identified total of 70 latent safety threats only by doing a retrospective analysis of these team scores and the checklist from the team training in Situs. And they are comprised of on the domains of communication skills, resource, equipment, medication, and medical management. And if you look into the sub-thematic analysis, you will find out lots and lots of good things, stuff comes out of it, that the PPE is not being worn properly. There's a need for hyperkalemia pathway. NRP training is needed, various medication error, the various challenges regarding insulin infusion ordering or any prostaglandin infusion ordering comes up. The team dynamics, team communication was also a major theme of it, as well as the location of the equipment or availability of the equipment. One of my colleagues in Canada has done the similar kind of work, which is very well known as a trust study in the adult world as well, especially in the trauma team training in Situ. And they identify 843 latent safety threats by doing 12 simulations. And if you see the thematic analysis, it is almost similar as I have shown you earlier. So what happened out of this? Various pathways and order sets have been generated, and a lot of system level changes, implementation happen because of these latent safety threats identification before it will reach to the actual patients and before we will wait for the Swiss cheese model to align properly. The next thing, which is Dr. Taj has talked about it a little bit briefly, is acute event clinical debriefing. Acute event clinical debriefing is another strategy where you can debrief after acute events have happened in order to identify what went well, what are the areas or opportunities to improvement are, and what are some of the strategies that the stakeholders or the people who are actually working in the clinical environment can bring it up. So if you look the history of acute event clinical debriefing, it's not very far away. It's almost 2014, this literature is. There's a national need assessment was done by Walter Epic and colleague and come up with the need of this kind of work in the emergency departments to be implemented was found to be very timely. And then in 2015, Adam Cheng and Kessler, David published this whole practical guideline with a step-by-step process how you can implement clinical debriefing. And it doesn't matter a big setting, a small setting, they have talked about all of this in this article. So last year in January 2021, we implemented this hot wash emergency resuscitation debriefing process in our emergency department. And we keep a standardized tool, very simple, and we talked about only 3 domains, that is teamwork, medical management, system related issues, and we talked about what went well, what areas are there to be improved, and then what are your recommendations, if any, to be incorporated. Almost 43 of such events have been debriefed. The average time spent was 14 minutes. Most of them, interestingly, was debriefed by in-charge nurse, 60% of them, while 25% were debriefed by both MCSN and the MD. The most of the participants which got missed were surgical specialties and anesthesias, and the reason for not to debrief are busy ED environment, lack of time, handoff time, and the events does not deem to be necessary. And what we do with these events, time-sensitive gaps are acted upon immediately. Otherwise, other performances gap go to the committee monthly meetings, committee meetings, including trauma, resuscitation oversight committee, and the safety committee. And then it was brought upon on a wider scale to hospital-wide committees. And based on this hot wash debrief, we have implemented targeted simulations, we have implemented new order sets, and we have made so much changes into our EMR that is user-friendly and that has got some forced actions that will prevent the healthcare professionals to end up doing some big mistakes. The fourth point is how academic EDs can support community using simulation. This is a big kind of an area which I want to highlight, and I think to the best of my knowledge, a lot of big emergency department in Pakistan is doing it to provide community care. Even in Canada, 85% of pediatric resuscitations or pediatric critically ill or injured patient go to the community EDs, where trained pediatric emergency medicine physicians are not available. So it will open up a whole era of what we call it as a hub and spoke model, where academic centers, big academic centers, will support the community centers in terms of consultation, in terms of training, which will work as a hub and spoke model. So the track which is translating emergency knowledge for kids, is based on the similar model, and what they are doing, in addition to developing resources and tools and doing research, they are also implementing lots and lots of education. And what they have achieved almost up till now, 165 plus education sessions of almost 2,400 plus healthcare professionals has happened up till now, and almost 80% of them are simulation based. There's a track app which is very easily and free access available, and you can download it on your iOS or Android phones, and this is the website link. If you look at such initiative in the literature, they have shown to improve the pediatric readiness score by almost 12.9%, and then an improvement in the coordination of pediatric care by almost 50%, which are impressive number. The last thing which I will be talking about in the last 1 or 2 minutes is the Cpr Coaches, which is a simulation-based strategy to improve the outcome of the cardiac arrest. The literature has shown recently that implementation of the CPR coaching not only lead to the adherence of the Pulse guideline improvement, but also leads to the improvement of overall CPR quality by almost 31.8%, and also higher ROSC in comparison to group where CPR coach is not available. This is a small video where Bethany Hunt, which is kind of a lead person who implemented the CPR coach, is doing in providing some training.
Two breaths. Two breaths. Okay, keep going. Can you come around and pull this all up for me?
5, 6, 3,
We just lost this all.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Second breath.
Breath.
You need to go a little bit faster.
2,
You're going to try to get to 110.
5, 6, 7, 8.
And then CPR coach role has been shown to decrease the workload, cognitive load from the team lead as well. And it will improve the outcomes definitely by having such a role during your resuscitations. So thoughts for later is that simulation role is not limited to teaching and learning. It has got a more broader role in ensuring patient safety and improving quality of the care. And then simulation can lead to system level changes, even in the low resource setting. With this, I would like to say simulation is a growth continuum and a paradigm, and it's not just a one-time event that you can use for providing teaching and learning to your learners. Thank you so much. Please, I have shared my email address. If anybody is interested into knowing more about such project or want to collaborate or support, I'm always happy to talk more about it. Thank you so much.
Thank you, Dr. Jabeen. Now I would like to welcome all of my speakers for the panel discussion. Dr. Taj Hassan will be chairing the panel discussion today. Dr. Jabeen, Dr. Megan, and Dr. Lubna Mushtaque will be here today with us. Dr. Saima will moderate the session panel discussion for now. Thank you, Dr. Saima.
Okay. Welcome, everyone. Can everyone hear me? Yeah. Can you hear me okay now?
Yes, Dr. Taj, we can.
Okay, thank you very much. I'm sorry about that. Dr. Simon, sorry, I'll let you lead. Do you want to introduce?
Okay.
Thank you.
So thank you, everyone, and another warm welcome from my end for being a part of our Icon session. It is a pleasure welcoming Dr. Taj Hassan, Dr. Jabeen Fayyaz, Dr. Megan Rybarczyk, and Dr. Lubna Mushtaque here for the panel discussion. It has been a fruitful 1.5 hours up till now, and I would like to thank all our speakers, for helping us understand the role of leadership, the role of innovation, and the role of simulation in patient safety, and establishing a hospital culture that is safe not only for the patient but also for the people who are providing healthcare to these patients. So to chair the panel discussion, I would like to invite Dr. Taj to lead the way, please.
Okay. Thank you, Dr. Saima. Just to congratulate you again and your team, Dr. Saima, for having put together a fantastic track, and to Dr. Urooj for having led us through so well. We got lots of questions, and Megan has also joined. So welcome, Megan. And I think we've got Dr. Lubna joining in a few moments. So we've got about half an hour or so in which to cover. And I was wondering if I could start with you, Megan, please. It was a fantastic talk and so comprehensive, all the work that you've been doing with the CPIM program. I just wondered whether you might be able to summarize, well, what would be the best bang for buck approaches that you've come across in terms of methods of both asynchronous learning and delivery that you found? What has been has received the greatest feedback from trainees?
Yeah, and Dr. Taj, thank you so much for that, and thank you for whoever posted that question. It's a pleasure to be here with everyone today, and thank you so much to Dr. Saima for organizing this session. Again, yeah, a great question. Which ones are the best, bang for your buck in terms of these different methods of learning? I will say from the experience with the CPIM program, a lot of the programs that I already mentioned, just in terms of like Google products, Google Classroom has been very, very useful. And is free in terms of signing up with a Google account. There are many, many different things that you can do with the Google account, from Google Forms that you can use for things like feedback and tracking attendance, tracking logs of things. You can use the classroom itself to post recorded lectures, which you can record even using like PowerPoint or Zoom, which again is free as well too. And you can integrate that with different programs such as Edpuzzle, which will allow you to make those lectures interactive by embedding questions throughout. So I think when thinking about some of those free applications, those have been very, very useful just in terms of developing content, posting it online for specific learners to engage with and utilize. Then just in terms of thinking about more interactive sessions, not just the asynchronous learning, but interactive sessions using applications such as Zoom or any other video conferencing application. A lot of them are free that you can interact with participants. And then during those sessions, making them very interactive using programs such as Kahoot, Poll Everywhere, all of those. And all of these are free. Usually, for doing larger courses, sometimes you have to pay for extensions or additional space or things like that. But pretty much all those have basic programs that are free and easy to use and very user-friendly. And allow for participants to engage mostly on their own time. So, great question.
Okay, thank you. Dr. Lubna, welcome. It's lovely to see you. I think we just lost your picture for a second. Can you hear us okay, Dr. Lubna? No. We might just have a connection problem. I'm just gonna move on, Dr. Lubna. When you're able to hear us, and please just let me know, and then I'll come back to you if that's okay. I think connection's a little weak. Okay, so let's move on to Jabeen, because Jabeen is up bright and early, as is Megan, over in North America. So Jabeen, as ever, fantastic talk. Thank you so much. The question I had for you was, what are the challenges of embedding change into emergency department settings in Pakistan? You know, where obviously a number of, you know, fantastically trained emergency physicians like Dr. Saima, you know, if we could clone Dr. Saima 1,000 times, it would be much easier, but we can't. So what are some of the challenges and your tips on how we deliver in such environments?
Yeah, I would say, if I would have to translate or say it in a one word, it is being persistent. Starting small and thinking big is the answer. It is so interesting that we think that in North America, and Megan can echo with me, it is very easy to do things. I can tell you it is equally difficult, and challenges are almost the same. All these programs which I have shared, it takes years to get implemented, and we have started maybe once a month, or maybe one in 2 months. And then we have scaled to this level over years, over like the team training in Situ is almost now 8-9 years old. So I would say starting small, being persistent, and then taking the challenges as an opportunity, and then embedding small changes in your system will become a change in culture, and then you can scale it later on. This is my one advice to everyone.
That's so reassuring for people like us in the NHS, where we have even less money, Jabeen. So you know, so no, that is good. You know, it's nice just to know that you've fought through all of those challenges, and building up gradually is a top tip. That's very, very good. Thank you, Dr. Lubna. Are you back with us yet, or is it still seems to come in and out? I'm just gonna keep going, and hopefully fingers crossed, we'll be able to sort Dr. Lubna's connection out very soon. Megan, I'm going to come back to you. There was a bit of a question about healthcare being an industry, and now the next thing is is business. How hard is it going to be shift the focus back from business to actual quality clinical care? Obviously, asking that question of an American emergency physician, where the United States spends 18% of GDP on health. So you're an expert then, Megan. Tell us the top tips.
Oh, that's a fantastic question, and I wouldn't say I'm an expert in that. I think from looking at it from the North American standpoint, we are definitely not the best in terms of thinking about the focus of healthcare. I think I will add on to what Dr. Jabeen had said, just in terms of starting small. Very, very small changes can then lead to larger changes, and they're often easier to propose to leadership in the healthcare setting. So if you come to your leadership with a small proposal that doesn't cost quite as much but can have a big impact, you combine several of these together, and that can have a bigger impact and doesn't cost a lot of money. Also, just in terms of approaching the leadership, who are potentially sometimes more focused on the business of healthcare or even efficiency, just proposing some of these initiatives in terms of that language. There's a lot of things that perhaps folks within the department might notice that could potentially lead to more efficiency in the system, even just like saving staff 1 or 2 minutes. Those can add up. You think about 1 or 2 minutes per patient, excuse me, and you see 300 patients a day, that all of a sudden equates to 5 hours of increased efficiency. And a lot of times increased efficiency can lead to increased or better patient safety. So changing maybe the language on how you propose some of these initiatives, maybe more toward efficiency rather than safety, can kind of slowly
and calculate some of those changes without, some of the leadership or even some of the business administration even seeing that. Also, just in terms of thinking about longer term initiatives, it's really asking people to invest upfront for then benefits that they're going to see further down the line, and using things like your electronic health records, incorporating that kind of technology in order to get data. So a lot of these folks think in data as well too, in numbers, and using that to kind of bolster up your initiatives and provide evidence for what you're doing can often be helpful as well too. So, thinking about numbers, thinking about data, maybe reframing how you sometimes start the discussion with folks. And that'll slowly over time, I think, help change it. But it's a challenging situation to be in, but I think it's definitely possible. So,
yeah, no, thank you.
Can I add one or 2 points?
Of course,
what Megan had said. First of all, what helped us sometime as well, because we know that how the hierarchy or higher admin know the language of business. So talking to them in a business language, that what cost saving you are doing by saving the time, by improving the errors. So that sometime also help. And then involving the stakeholders, all the stakeholders early on, although they will be a silent partner, silent people in your group, involving them early on is kind of a strategy that worked for me in some of the projects, which seemed challenging in the beginning.
Yeah, absolutely. I love both of your answers. I think that's absolutely right. Starting small, engaging stakeholders, and building vision. One of the things, I suppose, what you're both saying, which I've sort of struggled with over my career. Perhaps I'm a slow learner or something, but I think trying to get the key players in your own department and then working out the changes that you think are create big levers, big positive levers, and then working out from that the next sort of layer of the penumbra is to find the key players who will support you, who will provide air cover, so that others are fighting your corner. Because that's one of the things, you can honestly be saying this is the best thing since sliced bread, but until you get one or two other heavy hitters in the system who are fighting for you, that becomes a much easier battle. So I think those 2 or 3 key points are really vital in the business world. Now, I mean, Megan, you mentioned EHR and everything, and obviously, again, in North America, it's probably much more established. In the UK, I mean, my own system in Leeds, we're one of the 3 largest major trauma centres in the UK, but we actually only implemented an EHR in the last 3 years. Just before the pandemic, and we're still developing that to collect the right discrete data as well as the right narrative data so that it's easily analyzed. What do we do for Pakistan? How, and I know this is a bit more of a challenge for you, Megan, because you've probably not been exposed to Pakistan as much, but perhaps more, Jabeen can start us off on this, because you've been there and done all of that. The best of both worlds, Jabeen. So what do we do for Pakistan to where EHR is, light years away, and collecting data is power? What are your top tips there? Saima may be able to help us as well, perhaps.
Yes, so you might have seen me smirking. So that the reason I was doing that, because electronic health record, I think, is one of the strengths of our health network. And I think we were the first paperless hospital in Pakistan. And taking it from there, we've spread from Karachi to 11 campuses across the whole country, and all of them are connected through electronic health record. And I cannot emphasize enough, and I would like to second all of you when you say that data is important, because that guides everything that you do. That guides your patient management, that guides your organizational flow, that guides your HR, that guides your policies, procedures, guidelines, and it should actually guide the legislature of a country, because unless and until you have data unless and until you have the right facts and figures to support what you're saying, it wouldn't really account to anything. Does not matter if you're banging your head against the wall, because as long as you don't have the figures to prove what you're saying, it wouldn't really count. So coming at your question, Dr. Taj, data retrieval, whether it's electronic health records or it's a paper-based system, that needs to be robust. And what we've learned from our experience is that everybody who comes out of medical school, we sort of think that they know how to put their notes and they sort of know how to put in the history and they know how to use the right terms. But I think in our undergrad medical education as well as in the postgraduate medical education, there needs to be a robust module on how to put in the right data for it to be collected at the time when you need to use it to guide you. So I think that needs to start at the undergraduate level. And once you've started it at the undergraduate level, it needs to be reinforced in the residency program. However, that being said, not all hospitals have an undergraduate or a postgraduate program attached to them. I'm basically talking about tertiary care centers located in bigger cities. So when you're talking about smaller setups, I think, again, capacity building and human resource training is the way to go. And I would agree with Dr. Megan and Dr. Jabeen and you, Dr. Taj, that you need to start small and you need to build it up. And it is not an easy process because it's all about a paradigm shift. It's all about changing mindsets. That takes a while. And just, staying persistent and not losing hope and just doing your bit to bring about the change. I think that should be the key. I would like to also inform Dr. Taj, Dr. Jabeen, and Dr. Megan that Dr. Lubna has joined us physically. There was some difference, problem in her connection. So she would be able to take your questions, Dr. Taj.
Okay, thank you very much. Thank you. I'm just going to let Jabeen finish, and then I'll ask Dr. Lubna a question, and then I think Dr. Saima wants to ask me a question, so I'm a bit worried about that. So there we go. Jabeen, over to you.
So I echo whatever Saima has said. The proper infrastructure for such kind of a culture of patient safety, because it's kind of a higher level thing. It is one step beyond teaching, training, etc. It's just like everybody being willing and open and being able to work together as a team is important. So for developing, like for cooking biryani, for example, you need to have all the correct ingredient. If you want to cook a biryani and you do not have a rice, you do not have all the spices, you cannot cook it. So the same is true for this thing as well. You need to have some component of infrastructure available. But if that is not available, it should not be a barrier. Like I work in civil. I was trained at Civil Hospital Karachi, and we used to do lots and lots of research. We have data. Yes, we have to struggle a little bit more, but small audits, taking out for quality research, for quality implementation or QIP process, only 10 charts or taking out 10 patients in a month time is enough to, and then monitoring it longitudinally, doing PDSA cycles, which are small, like 4 or 5 patients is okay for a small setting, in my opinion. So in a small setting where such infrastructure is not available, doing small audits or investing some time, having a person who is dedicatedly working for a quality improvement and patient safety in each department is the way to go.
Perfect. Thank you so much. Dr. Lubna, welcome. I'm sorry that you've had such troubles with, but you're just...
Thank you very much. Thank you very much.
So, Dr. Lubna, it was a lovely talk. I really enjoyed it. I wondered whether I could just ask you, so if I was an emergency physician in Pakistan working in a new department, trying to set up, to develop a just culture, what would be some of just the simple first steps? What are your top tips on just some simple first steps to try and build that approach?
Okay, thank you very much, Dr. Taj. As just you mentioned, and before I was listening, Jabeen as well, that small steps will make a big difference. So, if in Pakistan, in case of the development of new emergency department, I will recommend to develop a just culture. What just culture is? Just culture is actually the culture in which everybody in the organization or in the department feels free to raise the safety concern in a non-punitive manner. What happened that it's a long time, it's a debate between the paradigm shift of blame culture towards the just culture. If we can promote just culture, and just culture cannot be possible without the commitment of the leadership, then with the development of the just culture, when every physician in the ER, physician, nurses, paramedics, they feel safe by raising the safety concern. If they will raise their own mistakes in a non-punitive manner, I think this is the first step for the building of the culture, the safe culture. And to develop a culture, it's a matter of change management. And we all agree that change management is not a one-day dream. It will take a long time to develop, but somehow anybody should have to take a first step. So small step, the development of the just culture, and then the policy, procedure, and protocol guidelines will come after the just culture.
Okay, that's fantastic. So there's lots of questions coming in, and I'm having to control some of that. There was somewhere in there, I think, a question for me about one of the slides. I think I talked about spending an extra 2 or 3 minutes with the patient, which I think I've always been very, very committed to that, because if you do spend, just when you think you've finished that consult, if you can just actually stop yourself and say, okay, I'm going to actually now spend an extra 2 minutes. I'm just going to go over this again with you. I've probably said it already. Here's what I think is wrong with you. Here's what we've done for you today. Here's what's going to happen next. And here's what to do if things don't work out. I'm discharging you, but if things don't work out or things you're worried about, here's what to do. And I think that reinforcement is so utterly vital. And you can see it in people's eyes when because you connect with them in that. And it's very energizing, I think, for the emergency physician as much as it is the gratefulness of the patient. I just wondered what people's, and the question I got was, we have to be more productive, and spending extra time with patients makes you less productive. So I would say that actually that leads to less patient harm, less reattendances, etc. But I just wondered, for the panel, what sort of tips you have of the ways in which you engage your patients, and the ways that you embed that patient trust. What are your top tips for things like that? I just wondered who wanted to go first. Dr. Lubna, you're muted. Just muted.
Yes, I will go first.
Okay, perfect. Thank you.
Okay. So the small tips will be that you have to develop a culture of shared decision making for your patient. And in such shared decision making, you have to involve not only the physician but the nurses and the family of the patient as well. I think shared decision making, it's very important for the development of a culture. This is the only small comment from me.
Okay, thank you. Megan, what are your top tips on this?
Yeah, it's a great question. I think making your environment more efficient so that you can spend more time with the patient. So, regardless if you have, paper charting versus electronic health record, either way, making the notes and the records that the physicians have to fill out as efficient as possible, especially in the emergency department. And so then people are able to spend more time with the patient. Other ways, and similarly in other processes throughout the ED, from the time the patient checks in till the time that they're discharged. Anything you can do to make the environment more efficient will allow, you know, the provider to spend more time with the patient and then be able to have those conversations, engage in shared decision making. So, and then just, you know, looking at all the different steps on that and how you can make that more efficient for providers, how, and engaging the leadership and how they can invest in things that would make providers more efficient. That'll also then help. I think there was a question about, you know, as providers are expected to see more and more patients per hour, how can they do that? That's a way to do it. You know, look at the efficiencies of the processes, and then you're going to be able to spend the same or even more amounts of times with your patients. So,
okay, perfect. Thank you, Jabeen. What are your thoughts?
Yeah, my thoughts are, which I always advocate for, empowering your allied health professionals, like your nursing, your other colleagues, equally to be part of your healthcare system management. Like, for example, we have so many medical directives for our nursing colleagues that they can initiate them doing. For there are order sets, there are pathways which is implemented, and if that they fulfill that criteria, they are allowed, or they are able to initiate the management without a physician being involved actively, being passively there. So this will improve the efficiency and efficacy a lot, and it will make them feel as a part of team member, and they don't feel that they are nurses and they are physicianing. So I would say flattening the hierarchy, involving all the allied health professionals in the decision making, and then working role modeling that we physicians, nurses, respiratory therapists, clerk, social worker, RT, working all as a same team and toward the same goal. So this would be my tip.
Okay, thank you very much. That's brilliant. Gonna move on a bit now, and there was a recurring question in the chat about delivering quality of care and the quantity of care. And of course, we know in Pakistan especially, although equally applies everywhere else, that quantity quality imbalance is a real challenge. So I think this is actually a really tough question, but you know, in terms of on the resources available, I think the question is saying on the resources available, how do we best deliver quality of care? And that's a pretty wide-ranging and open question. So I'm sure that you've all got fantastic answers, as I've tried at length to give you more time to think. So who would like to go first? Megan looks like she's desperately keen to go first, so that's good. Megan, over to you.
Oh man, yes. I mean, this is a very, very broad question, but a great question. And I think we could probably all talk for hours and then start coming up with different ideas and going off on different tangents on different ways we could do this. But I think a lot of it boils down to some of the things we've already said. So in terms of thinking about delivering quantity care but maintaining quality, as Dr. Jabeen just said, you know, engaging the whole team and division of labor. I think, Dr. Taj, as you mentioned in your talk, you know, delegating different tasks and really trying to flatten out the hierarchy and even things out in terms of dividing that care and allowing everyone to participate as a team within that care. So I think first and foremost doing that, and that will help do that. Also, you know, just in terms of thinking about investing in people, as you mentioned in your talk as well too, we have to make sure that we retain the employees that we have now. It takes a lot to really spin people up coming into a new environment with orientation, getting used to the culture, getting used to the practice. And so really investing in the people that are here and now in the organization, making sure that the number of hours that they work is appropriate, you know, investing in just one additional staff member to help bring everyone's hours down by 1 or 2 hours can even make a big difference in terms of wellness and people's ability to provide high quality care. So talking with the leadership just about very small changes that can have an bigger impact like that, investing in people. It takes a lot in terms of convincing people to do that, because the benefits are not immediately seen. People are talking about investing a lot up front, but if you can really glean that data from either your electronic health or paper records on how care improves, and provide that data, how even just adding one additional staff member can help down the road, I think that can be really effective. So really, dividing the care, making sure that the hierarchy is flattened, promoting just culture amongst people, investing in people and the wellness of people to retain staff, can really help overall improve the quality of care and allow people to provide higher quantity of care at the same time. So.
Brilliant. Thank you. Dr. Lubna, I wondered what your thoughts on that are.
Yes, I will agree with Dr. Megan that with the shared decision making, I think if we can invest on our staff, the ER staff or ED staff, it will make a small thing make a big difference. And especially in case of those ER where the things are establishing in a very new, as a new department or a new area. Once you involve all your stakeholders, so definitely you have to involve your leadership also. Without the commitment of leadership and the shared decision making, I think we are not going to invest on our staff. So training, investment on our staff, and continuous improvement will take us towards our goal of patient safety and quality.
Perfect. Thank you. And Jabeen, do you want to?
Yeah, I think one of the very effective strategy that I have found that works well is not to talk about where we fell off or where our system didn't work. Is celebrating small successes, small wins, letting the staff know how does their contribution make a fruitful impact, which is so huge, sometimes motivate them more. So sharing not only the bad outcomes, but then sharing with them the good things that they have done will provide them motivation. And also, like we have in the last 3 years, a round which is called Amazing and Awesome Round, right? Other than the M&M rounds, where we talked about all the amazing and awesome things that we all as a division or as a department are doing. So this will bring not only the sense of fulfillment, but also is a good strategy to maintain the physician's wellness, especially in such a burned out environment or such a hectic emergency department environment that we all are working in.
Okay, thank you. Thank you. Actually, a couple of you have mentioned physician wellness and well-being, and it was something I mentioned as well. I just wondered about your thoughts about in Pakistan, where the cultures are so different to Western countries. What are the things that we can be doing, or that can be done in Pakistan that support physician and nursing wellness, team wellness? Because our nursing colleagues are as stressed by such difficult environments. So what are the things we should be doing for our emergency department teams in terms of wellness? And I'm glad Saima's returned to this. So Jabeen, I was going to start with you, if that was okay, because you've worked in Pakistan a lot. What are your thoughts on what can we do for our teams in guiding and advocating for positive change in this area?
Yeah, as I talked about, I know how much stressed our healthcare system is in Pakistan. But I would tell you, working in Pakistan and then Middle East and then now in Canada, the burnout is everywhere. Like wherever, which setting you are working, emergency department is a field that we have chosen for ourselves. So that is real. But having I think a dedicated team, like a dedicated role, someone in the department who will advocate for the wellness of all the staff physicians. Also having small processes of rewarding your staffs. Like we have a process in place where if I have done a teaching, I can claim hours, like it's not a lot, but a 1 hour off from my clinical work. So it's a very, very small reward, but it makes me feel valued that I'm getting something out of it. Now, and then supporting each other, like if anybody is in any of their family related or professional related commitment, and so providing that support really works in our emergency medicine field, which is quite stressful.
Okay.
Yeah.
Saima, just a couple of comments from you, if I may, on this really important area. Time is running out, so I'm just going to ask you just for a couple of comments, things that you might be doing at Indus or that you've seen elsewhere. What are the top things for helping our ED staff in this area?
Thank you, Dr. Taj. I think that's a very important question that needs to be addressed, and especially working with high volumes. When you have people just pouring inside the emergency department at all hours of the day, you need to be aware of your team members, what their strengths are, what their weaknesses are, aware of the red flags of burnout as a leader, because if not identified earlier, sometimes the person who is facing burnout does not him or herself know that they are actually this is what they're going through when they just keep on pushing themselves. Because I know the patriarchal culture, unfortunately, that we live in, boys don't cry. So you can't have somebody admitting that, okay, I need help, or I am at the verge of collapsing, because you just keep on motoring and you just keep on pushing yourself. So I think as all of you have emphasized, establishing a culture of safety, not only for the patients, but also for the physicians, that is important. You need to have a safety net. You need to number one, identify people who are on the verge of burnout or facing difficulties due to personal, professional, whatever reasons there might be. And then having mechanisms established within the ED and within the organization for them to, not go perhaps on a paid vacation to Switzerland, but as Dr. Jabeen has said, having small rewards or having small breaks assigned to them, having small physician retreats, healthcare worker retreats. And I will just give an example. During COVID, what we did, we have a very well-established pediatric oncology play area. And that play area was converted into a physician wellness area where, board games were placed and counselors were there and people were coming in and discussing their problems. So I think establishing something not on a very large scale, even within your own department, that helps. And letting people know that you're there to catch them if they're falling in any way. And it's okay to fail. It's okay to fall. It's okay to cry and lend a shoulder perhaps at times. So I think that's important.
Perfect. That is fantastic. Time is running out. I've got one more question, which I think was aimed at me, and I've ducked out of so many of these questions, so I've been lucky because that's chairing the session. But Dr. Ghazanfar has asked me about how we imbibe leadership into practice, as it's important in a country where emergency medicine is still establishing itself in Pakistan. And that's a great question. And as some of you will know, I think we've been doing great work in Pakistan Society of Emergency Medicine. There's a strategy group with 6 themes of work, and one of them is specifically around the development of a leadership academy. And Dr. Turab, who is one of the excellent emergency physicians in Pakistan, is leading that work, and a number of us are supporting her in that. And of course, all of you on this panel are fantastic leaders who are supporting Pakistan. We're especially grateful to people like Dr. Megan, who's done such fantastic work in supporting Pakistan. And so I think what we want to do through that strategy group is really continue to drive that change, and with Dr. Turab's help and others on the executive, develop this leadership academy. And there are so many domains. It like water, it seeps into absolutely every nook and cranny. We've got a fantastic opportunity to support leaders like Dr. Saima, Dr. Turab, and so many others who are doing such fantastic work. So I'm going to stop there now, and I'm going to hand back the baton to Dr. Saima to take over. So thank you for letting me do this, and thanks to the panel for being such fantastic contributors.
Thank you, Dr. Taj, for amazingly chairing the session. I couldn't have imagined anyone else doing it, and you've done a wonderful job. So thank you so much. All of the panelists and all of the participants who've been very active. I would like to especially thank Dr. Urooj Adnan, who is our Year 4 resident, one of the senior residents who did an amazing job in moderating the session. Dr. Jabeen, who is my class fellow and a very dear friend, who's been up since 4 in the morning, I suppose, and Dr. Megan as well, the same time zone. So these wonderful, wonderful ladies who've been part of our EM journey at Indus and in Pakistan, both in the adult and in the pediatric emergency medicine establishment, amazing clinicians and amazing educators from whom I've learned a lot, and so have the people around us, and it is seen in the patient outcome, which is improving, and the satisfaction level which has gone up. Dr. Lubna Mushtaque, who had to rush all the way from her office to the session, which is quite far away from where she's located when her internet wasn't working. So being here and sharing her experience with us, and always being in the lookout for the wellness of not only the patients but also of the clinicians. So thank you, Dr. Lubna, for being with us today, and thank you, Dr. Taj. I see that we've been keeping you away from the wonderful sunshine that is so rare in the UK. So it's amazing to see you glow in the sunshine. I hope you get a lot of vitamin D today. And thank you for chairing the session, and thank you for your participation and wonderful presence. We've all learned a lot from all of you today, and we hope to keep on doing that, learning with and from each other, so that it not only improves the quality of life and the quality of care for our patients, but also for the physicians and the allied healthcare providers that are our colleagues and our backbone while working in the ED, because there is no I in the team and we are all a team. So thank you again. Have a lovely day. Catch up on a little sleep and sunshine, and we will catch you soon. So take care of your good self.
Yeah, thank you so much. And Saima, and the whole Indus team, I would like to congratulate all of you for pulling up such a wonderful program and giving us an opportunity.
Thank you, Jabeen. So it was lovely having you all on board, and inshallah we will meet soon when all is well. So stay safe, keep on wearing your masks, and get vaccinated. And we'll catch you later. Take care of yourselves. Allah Hafiz.